Okay, start. Our lecture for today is about acute appendicitis. Anatomy. The vermiform appendix arises from the posterior medial surface of the cecum, approximately 2 to 3 cm inferior to the ileocecal valve, where the three bands of the tenucoli converge. It's a blind diverticulum which is highly variable in length, ranging between 3 to 20 cm in some people. The base of the appendix is constant in position, unlike the tip, which is variable in position and can be found in different areas. The appendix has its own mesentery called Mesoappendix. As we say, the tip of the appendix can have variable position within the abdominal cavity, either retrocecal or retrocolic, when long appendix situated posterior or superior to the cecum and ascending colon, which represents 65%, inferior to the cecum, اللي هو subcecal, 31%, anterior to the ileum, pre-ileal, 1%, posterior to the ileum, post-ileum, 0.5%, and pelvic, which is directed inferiorly. Blood supply, appendicular artery, branch of ileocolic artery, venous drainage to the portal venous system. Appendicitis is inflammation of the appendix. It's a very common condition in general radiology practice, and it's one of the main reasons for abdominal surgery in young patients. Epidemiology, acute appendicitis is typically a disease of children and young adults, with peak incidence in the second to third decades of life.
الو تفضل منو؟ حيدر؟ اقول لك هذا مو باوربوينت راغده.
نعم استاذ، بلي باوربوينت.
شلون دا يتقلب هيك يمشي؟
لا مو انا مسويته.
استاذ محمد.
يعني هو دا يبين واضح؟ ما اني
لا كلش واضح، بس نعم هو مو سلايدات تتقلب، يعني دا اشوف ان كونتينيوتي كانما.
لا انا دا اقلب يمي، يعني دا اقلب سلايد باي سلايد.
اوكي يلا
اوكي استاذ. يعني هسه اني فاتحه الباثولوجي، يمكم دا يطلع الباثولوجي؟
اي واضح تفضل.
Pathology, it's caused by obstruction of the appendiceal lumen with the resultant build-up of fluid, secondary infection, venous congestion, ischemia, and necrosis. Obstruction may be caused by lymphoid hyperplasia, appendicolite, foreign body, or other rare causes such as structure or tumor. General sign and symptom: localized pain and tenderness, which is right lower quadrant pain over the appendix, اللي هي المكبرني sign. pelvic pain and diarrheal, يعني pelvic appendix, flank pain اللي هتصير most common retrocecal appendix, right upper quadrant pain تصير بالsubhepatic appendicitis. Rebound tenderness, abdominal guarding, fever, leukocytosis, nausea and vomiting. Radiological feature of the acute appendicitis. نبدأ أول شيء بالplain radiograph, which demonstrates appendicolite, localized ileus, dilatation and air fluid level in the ileal loop and cecum, obliteration of the right psoas shadow, obliteration of the properitoneal planes, concave to the right, perforated. This is example of plain radiograph of the abdomen demonstrates small appendicolite. The properitoneal fatty plane on the right side is obliterated compared to the left one, which is well preserved. Also, the air-containing bowel loops are displaced away from the right lower quadrants. Another example of an AP abdominal radiograph shows calcified appendicolite in the right lower quadrant with dilated air-filled small bowel loops in the right upper quadrant. The left psoas muscle margin is normal, but while at the right side, the psoas muscle margin is not clearly seen. Ultrasound equipment selection and scanning technique. By using high-frequency linear or curvilinear array transducer, We have three steps: either supine position, placing the transducer over the area of maximum tenderness and applying graded compression by probe to displace the bowel gas away. Our landmarks will be either right psoas muscle or iliac vessels, appendix found anterior or in between these structures. Once visualized, confirm that it's the appendix by visualizing it in a transverse and longitudinal plane. Appendix appear as blind end tubular structure of less than 6 mm. Alternatively, the probe may be placed in the right upper quadrant over the ascending colon. يكون عادة non-peristaltic containing gas or fluid, traced down to the cecal tip, terminal ileum, and ultimately the appendix. A second step, if still cannot be seen, we turn the patient to the left oblique body position and scan parasagittally through the right flank parallel to the long axis of the right psoas. The appendix is appear anterior to the muscle. If still not seen, the patient returns to the supine position for a repeat attempt. هنا هاي الtonographic appearance. This is the longitudinal scan of the normal appendix. And this is the axial scan. We see the target sign of the appendix. Normal layer of appendix. It has the 5 layers as any layers of the bowel, which are the mucosa-lumen interface surrounded by hyperechoic lumen and hyperechoic submucosa أو muscularis propria, and finally الأوتر layer اللي هي السيروزا اللي تكون hyperechoic. بالأكزيال section نشوف اللومن اللي هو الميوكوزا surrounded by submucosa اللي هي hyper and hypoechoic muscularis propria. Ultrasound sign of acute appendicitis. Direct sign and indirect sign. Direct sign اللي هي non-compressible blind-ended aperistatic tubular structure in the right lower quadrant, dilated more than 6 mm in diameter, wall thickness more than 3 mm, hyperechoic appendical leaf with posterior acoustic shadowing. Target appearance اللي شفناها بالأزيال section اللي هي hypoechoic fluid filled lumen, hyperechoic submucosa and hypoechoic submuscularis layer. Color flow. شوف peripheral wall hyperemia reflecting inflammatory hyperperfusion seen in early stage, which is the indirect sign اللي هي periappendiceal fluid collection, local abscess formation. This is example of grayscale ultrasound, longitudinal plane and transverse plane with colored tubular structure surrounded by hyperechogenicity of the fat, which indicate infiltration of the mesenteric fat. And by Doppler there is peripheral wall يكون يعني correct measure يكون from outer wall to outer wall اللي هي هذه measurement should be from outer wall to outer wall. This is the case of acute appendicitis or focal appendicitis. Color Doppler image of the right lower quadrant show a large father with a normal proximal appendix. This is the case of perforated appendicitis. Here we see the blind end tubular structure. This is the target sign by transflowing with periappendicular fluid collection and small bowel obstruction. These images show the difference between acute appendicitis with the preservation of submucosal layer This is the subhepatic appendicitis reveal a blinded end tubular sections here. This is the target sign by axial transverse section. This is a case of retrocecal appendix, يعني dirty shadow or bumpy gas appearance and the retrocecal appendix behind the cecum. A false negative result اللي هي retrocecal appendix inflammation confined to the tip, therefore demonstration of the entire length of the appendix is important. A false positive result اللي هي medial diverticulitis, PID, epiploic appendicitis, appendiceal mucocele and cecal carcinoma. CT scan. CT is high capacity 7% for the diagnosis of acute appendicitis. Allow for alternative causes of abdominal pain also to be diagnosed. The need for contrast, IV or oral or both, is debatable and varies from institution to institution and diameter. Normal contrast fold appendix. This is the proximal of the appendix, and this is the distal end of the appendix. Dilatation more than 6 mm in diameter, wall thickness more than 3 mm in diameter, surrounded with wall enhancement and arrowhead sign. appendicular periappendiceal inflammation or mesoappendix, extraluminal fluid, phlegmon اللي هي inflammatory echogenic inflammatory mass, and abscess, gangrenous appendicitis, and a precursor to perforation. These two image axial CT scan show the difference, the contrast to before and after IV contrast. Show the benefit of eyes, show indeterminate because the appendix is not confidently visualized, while the enhanced scan show dilated appendix with thick calcification of the appendix. Axial enhancement of the appendix with multiple appendicules and show small bowel areas. This is coronal CT scan of the subhepatic inflamed appendix, and this is contrast enhanced CT scan demonstrated arrowhead sign, show funneling toward the inflamed appendix in arrowhead configuration. The presence of this sign indicates extension of inflammation from the base of the appendix to the cecal wall. This is thickening the cecal wall adjacent to the inflamed appendix. This is a case of perforated appendicitis in 3 different patients. Axial CT contrast in extraluminal air. In B section, we see pelvic fluid collection in keeping with abscess, are highly specific for perforated acute appendicitis. MRI modality for suspected acute appendicitis in pregnant patients or in children where protocols include T1 weighted image in axial plane, T2 weighted image and single shoot 5 spin is image with 5 suppression in axial image, diffusion weighted image in axial plane, T contrast highly optional. مو شرط دائما انه يشتغلوها. The MRI characteristic of normal apticum, a diameter measuring 6 mm and less, a wall thickness of less than 2 mm. It has similar to the intensity of surrounding bowel, the cecum والإليum. The low luminal signal intensity on T1 and T2 sequences depending on the content. No periappendiceal change are present. اللي هي a large appendiceal diameter more than 7 mm, thickened wall more than 2T weighted sequence. Periappendiceal inflammatory changes, hyperappendicular is usually low signal intensity on all sequence اللي هي the focal signal voice affect focal fluid collection, abnormal wall enhancement on post contrast sequence. This coronal T2 of normal appendix and inflamed appendix. T2 weighted image without and with appendix with periappendiceal fats and fluid collection. The extent of inflammatory changes is better observed with fat suppression. Appendicular complication. Perforation, most specifically suggested by seen as periappendiceal phlegmon and fluid. Generalized peritonitis due to perforation, the most frequent complication of perforation. CT راح نشوف related around the adjacent bowel lobes. Third complication اللي هي bowel obstruction and rare complicating septic thrombophlebitis is the thrombotic occlusion of the portal vein or its branch system, which is a rare complication. Treatment and prognosis. Treatment is divided into whether the appendix is abscess formation or not. If the appendix is not perforated, treatment is appendicectomy is performed. In majority of cases, an open appendectomy of the right side of the abdomen. If perforated, an open surgery is often done with sites with abscess. Treatment includes drainage of abscess by percutaneous catheter placement. Appendicectomy can be performed at a later date after abscess has been resolved. Thank you.
شكرا جزيلا دكتورة رغد.